I'm back. So we've got another live today with my friend Abid Faqir from Scotland. And he has a similar practice like mine in the sense that he does surgical restorative side of implants. So let's see when he comes on. And my dad is on. Delphine. Hey, there he is. Let's see if my phone wants to work though. There we go.
Here we go. Hey,
Kyle, how you doing?
I'm doing well. How are you?
Yeah, very good, man. Very good. Very
Good.
good. We're totally on different timelines here, aren't we?
Yeah. So what time is it in Scotland right now?
It's 8 p.m. here.
Okay.
8 p.m. Yeah. And it's 1 o'clock over there. Is that right?
Yeah, 1 p.m. here.
Very good. Very good. And have you managed to get the little man to sleep?
Well, almost. He's gonna eat lunch and then he's gonna go take a nap. So
Very
we'll
good.
be good.
Very good.
Yeah. Yeah.
Very
So
good.
how's the COVID in Scotland?
I mean, I'm pretty sure it's very, very similar to you guys. We're in well, not full lockdown, but pretty much, lockdown with a little bit of access to outdoors.
Yeah.
But man, it's proper eerie. It's very weird.
Yeah.
It's hard to get used to. What about yourselves? How are you finding it?
Yeah, we've been okay. Yesterday we went for a drive without leaving the car. Just got in the car, drove around the city, and came back. And that was weird because we went down like the Sunset Strip right where my office is at 5:30 p.m., which is usually like gridlock. And there was nobody. We were just cruising. So it was, yeah,
There's something nice about that as well. There's some
that's
positives to
true.
it.
Yes.
Definitely
So
some positives.
why don't you introduce yourself for my followers that don't know who you are?
Okay, so I'm Abid Faqir. I'm a dentist based in Scotland, primarily in Glasgow, which is a city to the west coast. And I've been practicing dentistry for around 20 years.
Mm-hmm.
20 years. And primarily in implant dentistry, which is where we get sort of the connection, yourself and I.
Right.
I'm married, 3 kids.
Yep.
So just a busy, normal life. That's what I
Yeah. So I know you're doing a lot of implants and prosthetics. Are you doing traditional restorative dentistry at all?
So only when it's involved with implants. So when
Got
we
it.
have
Yeah.
a case,
Similar to me.
combined case, combined case, maybe get involved with the restorative side. But even then, we have some amazing restorative guys in our clinic, and they'll usually take over. But as
Right.
it's restorative driven anyway. So
Yep.
the starting point's always with them anyway. So we usually get involved much later.
Right.
Yeah.
Right. Yeah.
Yeah.
It's pretty similar to me now in the sense that I'm only doing the tooth-borne restorative if it's involved in a case where I'm doing the implants or the implant restorative. So yeah, pretty similar in our cases. And are you using multiple systems now?
No, I'm only using Straumann now. And I made the move over from Nobel Biocare around probably about 18 months to 2 years now. I had about
how do you like it?
Yeah, I'm absolutely loving it. Really, really enjoying it. Yeah, so I mean, it was 18 years with Nobel.
Yeah.
So it was a big, big move.
Yeah, I bet.
But one of the biggest factors is, it's not only are the companies very similar,
right?
But I think the sort of protocols, the implant is very similar to what I've been doing. So it fits into what I do with my patients. We all treat different patients in a slightly different way. to get to the same end point, but it fits in really well to that. Fits in really well to it. You're a Nobel guy, aren't you? Yeah.
Yeah, I use Nobel. I also use MIS. Those are kind of my two systems.
Yeah.
I'm similar to kind of what Thomas Linkovicius says, is that you can use any system, and you just have to know how to use that specific system, right?
Yeah, absolutely. I'm really, I've been interestingly watching your collaboration with Thomas and your no bone loss. As you know, that's one of the biggest, probably one of the biggest issues we have in implant dentistry, to try and maintain that bone, and to set out that whole no bone loss. I think is great. Absolutely, and it sort of brings it home to everybody. That's what we're trying to achieve. Long-term stability.
Right. Yeah, because I think that's one of the biggest problems we have, like you said. But there's so many people trying to fix the periimplantitis, and we know that in the research it's very low success rates on that. About 30%. If it's 30%, if it's not a smooth surface.
Yep.
And so the big challenge with that is we have to teach people from the beginning, right, how to avoid it, because fixing it just kind of doesn't work.
Yeah. And to be fair, the majority, I would say, of periimplantitis is usually caused by us, by the surgeons, in the planning and the positioning. So, as you say, if we can get that right from the beginning, that's probably the way to fix this. Listen, I've got periimplantitis cases as well, and if I look back and have a close look at it and understand it, there's always a little bit there that I think's actually, do you know what, that's what it was. And like you say, at least we know what the issues are. It could be worse. We could have an issue where we don't know how to fix it.
We could say this,
Exactly.
Yeah. Well, I think that's what's really important about those concepts that Thomas really brought to everybody, is avoiding from the beginning, but also being able to look back at your own cases and know why it happened, and say, that's right. My tissue thickness wasn't there. I didn't place the implant deep enough. I used the wrong materials. And there's all these trends in implant dentistry that kind of turn into dogmas, right? And then people don't change, and they do that for the rest of their career. And I think that's become a big problem.
Yeah, and it's like, as Thomas said, it's about changing the mindset. People ask me why so much guided, and why when it's such a simple case. And I usually go back to this and I say, because if I look back and I look at the cases where maybe there was periimplantitis, it was usually a positional error. And if I can use a tool to try and maximize that, improve on that, well, that's why, maybe 60-70% of our cases are now guided. Even the simplest ones, just for that reason, not for any other reason, because, I'm sure, like you, we can put an implant in, but it's about trying to get it as precise as possible. So it's
the
just
process easier for the patient, for you, less stress,
predictable, easy to work with, and it's probably the way to teach it in the future as well.
I agree. People always ask me that. Well, you brought up two good points. Let's say the first point was using guided surgery on simple cases, right? And people always say, it's just a single tooth. Why do you have to use guided on this? And what I always like to say is, I actually think that guided is more important on a single tooth than it is on a full arch. Even though I use guided for everything, but if I had to pick one, I would actually use the guided for the single tooth. Because on a single tooth, if you're off by, a millimeter, that could be a food trap, that could be a failure, that could be, fracture of the material. But on a full arch, you have a little bit of play. Now, like I said, I still use guided surgery for everything in my practice. And the second point you brought up was teaching. Do we teach people from the beginning guided surgery or not? And I go back and forth on this because I think we do need to know how to place an implant freehand in case something goes wrong.
Yeah, yeah.
But I still think we should teach guided surgery from the beginning. So it's a hard thing.
Yeah. I think the other thing is with guided surgery, people think it's just the production of a guide and using a guide, and they forget it's the whole virtual surgery, the ability just to do a surgery without even having to numb the patient up and just have a free run at it.
Yeah.
And I think just that part of it, as part of the treatment planning process, with starting out, I think it's so valuable, so valuable.
Yeah, that's what I like about guided surgery is that it forces people to plan ahead.
Yeah, absolutely. And it's interesting the thing you said about single teeth and full arch and the need for it. I completely agree. And in actual fact, the other point you said was they have to know how to place it freehand. The complications I've had with guided surgery are always with full arch, because the guide can break or something will come off or something. Whereas with single teeth, it's just a little bit more of a finesse to it. I think it's easier. So it's interesting that you think the same thing, and it's obviously it's just because we're doing it more and more that we're starting to see where the deficiencies are and where it can let us down. And it's about managing. It's like anything else, about managing complications.
Yeah.
And it's complications can be at any stage, during surgery, after surgery. It's just
totally true. I've found that since I've been doing guided surgery, it's been a while since I've been fully guided. I mean, for 5-6 years, something like that. Maybe more. Maybe 8 years actually.
Right.
It's become so much more routine. Of course, there's still complications, but it's not during the implant placement. Usually, is when the complication is. Oftentimes it's after that, or it's in the restorative process, and it kind of takes that portion of the workflow, simplifies that, so that we can focus on other things.
Yeah, absolutely. I think you're totally right. I mean, it has also evolved so much. Guided surgery for me 10 years ago was this whole teeth in an hour concept, which it took a while to get not rid of that, because one of the problems I find is that companies make it too gimmicky sometimes. They call it teeth in an hour, teeth in a box, smile in a box, all these things, and I just think they take the sort of just the qualities of it out of it. Patients think it's a bit of a gimmick, or it's not real. It's so I think once you get that away, you start to get people to understand really what it gives. Then it's definitely a no-brainer. There's no doubt about it.
So what are some new concepts or new treatments or new things that you've brought on to your practice over the last 2 years? And we can keep it to kind of perio prosth.
Yeah, I mean, it's probably more a matter of sort of intraoral scanning is one of the things. I'm sure everybody's doing that, and probably more advanced than I am. But actually, a little bit different from that is more the digital aspects of treatment planning, of treatment communication.
Okay. Yeah.
So just the way I communicate with my patients. There's far more showing them 3D planning, getting them involved, getting them understanding what you're doing, communicating treatment plans with them. Or you used to use Nobel Clinician. We use other programs now, but I think communication has improved so much with our patients, and it's probably because we're becoming far more digital in our practices. And that's probably one of the biggest things that's changed in the practice, to be honest. And that's probably come more about with intraoral scanning, with things like Invisalign and that aspect of treatment in the clinics. that's brought that aboard. Not so much implant dentistry, probably more the cosmetic part of dentistry has changed that. It's a big thing for us, yeah. What about yourselves? What's the big thing for you guys?
Well, just going off of what you said, I found that having that digital workflow to show the patients what we're doing, how we plan, how we print guides, et cetera, it makes them value the guide. And it makes them, like, I was talking to Mark Bose yesterday, and we were talking about, some patients, they'll even say like, oh, people do it without the guide. They're like, they get it, And I say something too, like, I never have patients that complain about the price of the guide. They complain about the price of the crown, they complain about the price of the implant, but they don't complain about the guide because they understand how important that is. Once you show them, once you have their skull rotating on an iPad and, you let them hold it, they get it.
Yeah. It's like anything else in life, let's say, for instance, we go and buy something. You want to touch it, you want to feel it, you want to get value for it, and so, and the majority of patients that have the type of treatment that we do have investigated a little bit. They've had the ability of being on social media, being on the internet. So they're probably 50% of the way there when they come to see us. Yeah. So understanding a guide, understanding the ability to put an implant in the absolute precise position. I always say to my patients, I say, it's like jumping out of a plane without a spare parachute. Why would you do it? Why not? Why not just have that spare one there? Why not? Let's get the guide. Let's just give me a little bit of help in what I'm doing, because I might have an off day. I might just have other things in my mind. It brings it home to you a little bit about what you're trying to achieve. So I think they understand it. I think they do.
Yeah. So to answer your question, what are new things that I've brought into my practice? Partial extraction therapy is one in the last few years. Tissue grafting more from the tuberosity, and more tissue grafting in general. It's just so many of my cases get tissue grafts now.
And is that because you're seeing certain results, or or you're speaking to individuals, or?
Yeah, so the tissue grafts really came. I've always had Sasha Jovanovic kind of pushing me to do more tissue grafts. And when I would look at some of my cases and I would look at some of his cases, when I realized the difference, what the difference was, it wasn't the implant position, it wasn't the bone height, it wasn't the lab work, it was the tissue quality and the tissue thickness. And then, when I first saw Iñaki Gambarino speak, I don't know when that was, 5 years ago or something, that like blew my mind. And I wanted to do anything he was doing. And he was big on tissue grafts, and especially from the tuberosity. And then the other thing with the partial extraction therapy was seeing cases that looked good at 1 year and then seeing them at 5 years and noticing a big difference. So that was hard for me. We have a question. May I ask what a tissue graft is and what is it used for? Good question. So tissue graft is taking gingival tissue from somewhere in the mouth. Oftentimes it's from the palate, sometimes from the tuberosity in the back. And we add that, or we graft it to other places so that we can grow more tissue in that area, have more protection from the bone, or for the bone, from the oral cavity, and get an overall better long-term result and more aesthetic result.
Definitely. I mean, the other thing with that is that I also followed Iñaki Gambarino, and listen, you and I both know how incredible, how gifted he is. And what a brilliant educator he is. But like you, I've done the no graft in 2010. Joseph Kahn. I've done graft. I've done dual zone, I've done tissue graft.
Yeah.
There's no doubt with tissue graft, with probably in certain sense tissue graft, it protects things far more than anything else. But nothing really is really 100%. And
Yeah.
it wasn't until I started to see, you know, our good friend Howie's work,
Yeah.
that I thought, by the way, you know, this is easier for my patients, simpler for my patients. There's no second surgery anywhere.
Yep.
And like you, I think we both probably embraced it at the same time, maybe about a year and a half ago.
Yeah.
And you know, touch wood, it's predictable and it's good. There's no doubt about it. It's good. I'm obviously we live in in the UK. We've got to be very, very careful with guidelines here. So I have to pick my cases.
Sure.
But it's very, very promising. I don't know what do you think of it? Do you?
Yeah, I think and we're talking about partial extraction therapy.
Yeah.
I love it, actually. I love it, but it's not easy. I think it's definitely an expert level surgery that is not easy out of the box. And I know some of my first cases that I did, getting the proper thickness of my shield was difficult.
Yep.
First ones I did were too thick. Then I went too thin. Then I kind of brought it back. So, but now that, you know, I've done enough of them, they're becoming more predictable. And the only complication that I've had with them so far is not reducing enough and having to go in at when was it? I think it was when I was placing the crown or something. I had to reduce a little more of the shield. So not giving myself that prosthetic space that like Richard Martin shows us and Howie and those guys.
Yeah. Tell me something. How does, I mean, obviously you work with Sasha. How does something like this sit with Sasha? How would he view partial extraction therapy?
Sasha's not big on partial extraction therapy. I think it comes from like his, 30 years of grafting.
Yeah.
I don't know if I've seen him do one now that I think of it. But
and
yeah,
do you think
I think in that camp, I don't know if it's as accepted.
Yeah. I think I found similar. You know, when you discuss it in certain circles, it's so loved, but in other circles, it's viewed very much as, we need to wait 5-10 years. We need to understand it, which is fine, which is a good way of thinking. We do need to wait to see results, but listen, it's a great concept. I was really, I was really looking forward to. My wife had said to me earlier on, "What are you going to speak to Kyle about?" And I said, "I want to ask." He does a lot of work with his plastic surgeons.
Yeah,
that's something that's really big for you. And I thought, I'm really interested to hear about that because you talk about that quite a lot. We don't see as much of that work here in the UK. We've not really seen as much, but I think some of my guys that are on here would love to hear about that. And
sure,
and I think, yeah, absolutely.
Yeah, so that's been a thing that I've really been trying to bring to the dental community, the medical community, is this interaction. It's like, I do this and you do this. I mean, we need to be talking, we're talking about the same face. So it was hard for me to get people to start listening to this. I started actually talking about this when I was still in dental school. I started doing research on this, looking into it. And it wasn't until, I don't know, maybe 5 years ago that people didn't think I was insane. Because I would always kind of pepper this into my lectures, right? So if I was giving like a full day lecture, I would give like 45 minutes and talk about lip lifts and plastic surgery, and people would just think I was insane. And then a few years ago, people started to realize, I think, how this could benefit everybody, benefit the dental community, benefit the medical community, benefit the patients. And what really helped was getting my good friend, Dr. Ben Talay, who's like the lip lift master of the world, to get on board with this and start spreading the word in the plastic surgery community. And so that was really cool. So now, like, we have facial teams around the world. You know, we have one here, one in New York, one in Marbella, one in Brazil. So we have teams that have incorporated facial plastic surgery and dentistry. And I think that it's really going to be the future. I think that incorporating these two specialties together, and similarly how we plan interdisciplinary in dentistry, you know, you may bring me in, a periodontist, a prosthodontist, et cetera, et cetera. We need to be doing that outside of dentistry as well. And so that's what I've been trying to do, and it's really starting to pick up now.
And again, just, you know, lip lift procedures. Just
Yep.
what exactly are we trying to achieve with a lip lift?
Yeah, so we're basically taking a senile upper lip, so older upper lip, right, longer upper lip, and shortening it, bringing it back to maybe where it used to be. Because oftentimes what we do is take wherever the lip is and we add 2 millimeters to it. And that's always been our accepted treatment in dentistry. But if the lip is lengthened or in the wrong aesthetic position, then we're doing all of this reconstruction, implants, you know, whatever, based on the wrong initial measurements. So by bringing that lip back up, we can then plan from there and have an overall better result. Because so many times what we do is we give our patients young teeth and an old mouth. You know, so they have like mamelons and they're white and, you know, perfect. And then, you know, the lip is still long, you can't see any of it, or the wrinkles are there, and it just kind of doesn't work. So by making the face a little bit younger as well, you know, whether that's injectables or whether it's rhinoplasty or chins or, you know, whatever, we can add a little more balance to the dentistry as well.
Excellent. Yeah, it sounds really interesting, and yeah, absolutely. I'm sure it'll be something that makes its way over here eventually. But it makes sense. It makes absolute sense tying it all in and doing it together because it has an impact. Teeth have an impact on lip, lips have an impact on teeth. Yeah, so absolutely, it's brilliant. So tell me some more about your practice, Kyle. Tell us who works.
So my practice is, so I have two great partners, Matt Nashad and Mark Helm. Very small practice. Our practice is like 100 square meters. Okay, so very, very small. And we're like the high-end, low-volume type of practice, right? So, you know, we see a few patients a day. We use rubber dam on everything. Everything is guided surgery. Really try to take our time, you know, this whole slow dentistry concept. And it's different than, I think, a lot of practices, especially in the United States or in LA, where it's like, let's see how much we can do at a very low price, right? And I was just never really excited about practicing like that. I always wanted to take my time, do the absolute best that I could. And, you know, in order to do that, you have to charge accordingly for that. So that's kind of how our practice is. And, you know, we do kind of everything in our practice besides endo and orthodontic. You know, between the three of us, I do all the surgical stuff and they do more of the restorative side.
Yeah, I've seen some of Matt's work. It's beautiful.
Yeah.
Beautiful restorative work. He's obviously very, very good, very talented. And it must be great.
Awesome.
Yeah, it must be great having somebody that you know can deliver beautiful aesthetic restorations when you put in the implants, you know. Because as you know, it's half the battle, you know. Trying to get that done as well.
Yeah, I feel very lucky to practice with these guys because, like you said, you have to have total trust. Hey, Valky, you want to sit here? Okay.
Hello.
You have to have. So you want to say hi?
Hiya.
That's my friend from Scotland. Yeah. You have to have total trust in your team. You know, so if I think, and that's the hard part with placing implants and having someone else restore them, or, you know, vice versa. Whether you're restoring them and someone else is placing your implants. I was never really comfortable with this. And I don't know how people that do only one side, I don't know how they do it. I don't know how they get rid of the control. And I think one of the things that I like about placing and restoring my own implants is that if there's a complication, it's me. I can't blame anybody, right? Which, you know, I guess is good and bad. But the good part is that I can definitely learn. And the other thing is, like, if I place the implant in a certain position, I'm the one that has to deal with the restorative side. And I think that's what is difficult in a lot of the US offices is that, you know, if I'm a restorative doctor, I send it to a surgeon, they place the implant. If it's good or it's bad, I'm the one that has to deal with it. And then on the surgeon side, if they place a perfect implant, but I put the wrong materials in, or I overload it, or, you know, et cetera, then they're stuck with the complications. So
I mean, also we mentioned earlier on about soft tissue grafting. I think when you do so much soft tissue work, it takes a lot of time developing it.
It does.
And it's very difficult then to let go, because certain restorative procedures can affect that. You know, so that's the part that I struggle with sometimes, you know, just letting that go and making sure that somebody's going to copy that tissue, respect the tissue. But listen, again, you know, it's changing. It's definitely, you know, probably more to do with social media, with people posting cases. I think the restorative side of things is starting to also catch up to understanding soft tissue. It's really getting there. Yeah, people are getting that understanding.
Yeah, I think in general, you're right, that people are becoming more aware of the importance of soft tissue in implant dentistry. And you know, it is those people like Iñaki and a lot of the Brazilians that are really bringing this to the forefront and making this important.
Absolutely.
In Scotland, is it similar to the US in the sense that you guys oftentimes have referral-based systems where some person does the implant, the other person does the restorative side?
There's a mixture. There's definitely a mixture. It depends what sort of practice. One of the clinics that I'm based at, where we have a number of specialists. But we have an endodontist, we have restorative guys, we have max fac surgeons. So there is a little bit of that, but again, it's starting to develop more and more. And probably because of things like DSD and Invisalign, people are starting to understand that everybody has a role now in the whole process. So we're probably behind the US in that way, but I think it's starting to get there. I think it's starting to get to the point where people know I'm really good at this or I'm really good at that, but I can't be good at everything. And it's just understanding that, but it's definitely getting there. It's definitely getting there. I've got, I mean, in Glasgow, I've got our good friend Jamil Gardi. Jamil's based literally a mile away from me. So.
Oh, really? Nice.
Yeah. So I get to spend time with Jamil, and he's been amazing pushing the DSD concept.
Oh yeah.
Just you know, probably the first guy in the UK to bring it here and really push it. So guys like Jamil will really help the profession and making us all understand that, you know, digital dentistry, team planning, and working with a team is so important.
Yeah. So someone's asking, is it all right for us to ask more questions? Yeah, sure. Ask more questions. That's what we're here for.
Exactly.
I know that you do a lot of full arch.
Yeah.
What is like your current protocol for full arch? Are you doing mostly like these FP3s, kind of the typical, you know, all on four? Are you going more FP1s? Like, what are you doing more of now? And what materials are you using, etc.?
Yeah, great. I mean, that's a brilliant question. I mean, it's probably gone full circle. 10, 12 years ago, it was as many implants as you could get in.
Right.
And then 5 years ago, it became the sort of
As
all-on-4.
little, yeah, all in
Yeah,
four.
exactly. What you can get away with.
Yep.
And then now, where am I? Now, if I can put a patient into FP1,
Yeah,
I will do an FP1.
yeah.
If for any reason it's cosmetically not going to be possible, then it's probably not FP2. It's probably moving more towards FP3 then,
Right.
because it's just far easier to
Aesthetically.
exactly, to make it predictable. And again, I'm trying to put at least 6 implants in if I can. And if I'm putting 6 implants in, and if it's an FP1, I like splitting everything up.
Okay. Where do you split? You like split it at, like behind the canines, basically?
Exactly.
Yeah.
Just from it's just easier to manage long term, I think. So that's and trying to be metal free as possible. So zirconia bridges, unless it's full arch again. If it's FP3, we've started to move away from the hybrid design and make it more zirconia. I use Pretau bridges, sort of zirconzan.
Yeah.
But I think the jury's a little bit out on that, on full arch zirconia. I'm not sure. We've not seen any issues or problems. But no, I think you're getting some more questions there.
Yeah, let's see. What options like braces or TADs or something else are there for someone who has a gummy smile but wants a lip lift? Yeah, that's a difficult one. Gummy smile with a lip lift. So most of the time, if you have a long upper lip and you have a gummy smile, you have maxillary excess. So usually that is a true orthognathic case. And impacting the teeth is, you can do it with TADs, but only to a certain point. Most of the time, those would be a true orthognathic case. And do you have any idea about that?
I mean, I think it's the classic most difficult case you can get, and it has to be. I think orthognathic surgery.
Yeah.
And maybe some people might think 42's maybe a little bit older, but I think 42-year-olds are very, very young. I'm 43 myself. So.
I know. It's funny how the older we get, the more like what old is, I remember thinking like 30 was old. I remember thinking 40 was old. And now I do the same thing. And like they're young. They're like 55.
Exactly. So 42 is definitely young. And I think, orthognathic surgery is probably the way to go with something like that. Well, at least to see it through, to discuss it and see what
I think, it brings up a good point. I think that orthognathic surgery is underutilized, especially now that with DSD and guided planning and, precision cutting, it's so much more minimally invasive. Oftentimes they don't wire you closed. They just put rubber bands. And I think it's really changed. It used to be, even 10, 15 years ago, it used to be huge, gigantic surgery. And it's still a big surgery. It's so much more predictable now. It's so much more minimally invasive, just like everything in medicine is going.
Yeah. I mean, I think orthodontics as a specialty has changed so much, probably more to do with Invisalign and lingual braces, etc. So I think minimally invasive is definitely the way everything's moving. I mean, how are things with regards to Invisalign in LA? Is it big? Is it huge? Is it the way people are going with orthodontic treatment?
It's big. Yeah, it's definitely big. And especially in LA, because we have a lot of people, in the industry, in the entertainment industry. Lingual braces are big too. I have a really good friend named Dan Grauer out here in LA that is kind of the king of lingual braces here too. When I was a kid, I was an actor. I actually had lingual braces, and then I had Invisalign in dental school, so I went through both. But yeah, I think people are going more towards Invisalign. Invisalign has become so much more predictable than it used to be. When I first had it, I had it in I think like 2005. So,
And long
15
time ago.
years ago.
Yeah, yeah,
It
yeah.
took forever. It took forever when I did it. And
Yeah.
the trays were harder, they hurt more. I think now the trays move it softer over time, and the technology is really, really increased. So there's a lot of things we can do. And, a lot of our friends on our WhatsApp group do crazy stuff with Invisalign. I mean, they do orthodontic cases with Invisalign. It's wild.
Yeah, I mean, I think it's Ronnie out in Singapore.
Yeah, Ronnie. Yeah,
Yeah,
Ronnie's amazing.
amazing work, he makes it look so predictable.
Yeah.
But
I saw one of Ronnie's cases. So one of Ronnie's patients moved to LA, and he needed some stuff, so he came, and he had this nice, beautiful wide arch, and he was telling me about his case. So he had his premolars extracted. They closed the spaces. Ronnie reopened them with Invisalign, expanded the arch because he was having airway issues. And I mean, it was amazing. You would have never thought this was possible with Invisalign. It was crazy.
Yeah, fantastic.
And we're talking about Ronnie Yap in Singapore.
Yeah,
So look him up.
yeah. And it's interesting you just mentioned the group there. We're so blessed. I mean, I definitely feel blessed being in that group.
Oh yeah.
It's just some of the world's best guys, the nicest guys, the humblest guys,
right?
And just so much knowledge, incredible amount of knowledge, and so giving. They're so willing to share.
I love that. I think that's changed a lot too, because I know that some of my mentors were telling me, 20 years ago, nobody shared anything.
Yeah.
It was kind of like, everybody was squirrels holding on to their nuts, right? And now everybody's sharing and sharing and sharing. And, oh yeah, you need that slide for your presentation? Here, take my case, or, you sent me a case too. So thank you for that. You sent me a beautiful full arch case.
Yeah. I think people are seeing that by sharing, they're getting themselves out there.
That's true.
People, and I think it's definitely embraced so much more. And I mean, obviously, our mutual friend Christian Coachman, he put that group together. And I've made great friends through it. So many good friends.
Yeah.
We go to Marbella in the summer, so I get to see Bruno every year.
Yeah.
And he's just such a great guy as well. Such a great guy
Bruno.
Who's again so giving, so much information and shares so much. And I think we've definitely found that. I've definitely found it through this group. There's some great connections. Great connections.
I think let's say the younger, I consider us young, right? The younger the younger group of speakers has kind of become closer, more giving, instead of so much in competition. And I think that's really nice for the community. We support each other more, we learn from each other, and the whole dental community benefits from that.
Yeah. I mean, on that point, we're obviously on Instagram Live, and with the current situation, there's so much webinar stuff that I'm doing.
Yeah.
We're teaching, and I'm speaking to the companies a lot. Yep. They're feeling very, very nervous about what's going to happen. I mean, what do you think? Where are we going to be in terms of teaching, in terms of learning and education going forward? Has this just given us that little bit of a kick we needed to get online?
I think so. Yeah. I think that the smaller study clubs may not happen as much, and we may only come together now for these big symposiums.
Yeah.
Because, when you think about it with the technology, why should they pay for us to fly, to eat, to stay in a hotel? We're away from our family for 2 days, to speak for an hour and a half, right? For an evening.
Yeah.
But I think that where education is really going, not necessarily right when we finish with this hard time, but in the future, is going to be having more VR, having more of these haptic feedback, like where you can feel it physically. basically a
Yeah.
hands-on, a remote hands-on. I think that that's where education is going, and that's where I'd hopefully like to contribute in that way, because it's
Yeah.
hard, like I would love to go take Inyaki's course, but flying to San Sebastian, Spain, and taking a week off from this and that and going without my family, and this is difficult. And just like it is when anybody comes to my courses in LA or wherever around the world, I get it,
Yeah.
and this education is spreading so fast that if we can make it more global, everybody benefits. I mean, the speakers benefit because we can be home with our families. The participants benefit because they don't have to spend as much money. They can also be home with their families. The one thing I worry about that is losing the interaction, losing the physical interaction. There's definitely something, we're talking and I feel like you're here, but I would much rather be speaking to you in person.
Yeah.
And so I just hope that it doesn't get to a point where everybody just stays home all day.
Yeah. Because webinars are one thing, but we get so much information from our audience. The way they're reacting, the way they're looking at us, the way they're perceiving information, and it allows you to change maybe your delivery a little bit.
You're exactly right.
Yeah. Whereas on a webinar, it's nothing really coming back, to be honest.
Right.
Yeah,
you can't tell your jokes because you don't hear any laughter, right?
Exactly. And there's obviously, actually, people want to know about not just your dentistry. They actually want to know, well, who is Kyle Stanley? What do you actually do? What do you do in your free time?
Yeah.
They want to understand that a little bit as well, So
it's true.
I think you're right. The big symposiums will stay probably for that reason.
Mm-hmm.
But it's definitely given companies and maybe certain individuals a little bit of a kick in terms of online education, because it's unbelievable the sort of need for it now.
Well, I had some of the companies that I was working with, and I was telling them for years, you guys got to do webinars, you guys got to get an Instagram, you guys got to do all this stuff, and they were like, because there's so many of these companies are so corporate, and they're ran by big venture capitalists or big banks or whatever, that they didn't see it. And finally, when some of my sponsors got on Instagram, started doing webinars, they realized the community that we have. It's like you can go to university on Instagram, you can go to university on YouTube, learning from some of the best. You can't physically practice, but as far as knowledge, I mean, there's just so much knowledge out there.
Yeah, absolutely. And you're also, so I don't know if your listeners know, you're also so involved with AI, artificial intelligence, and I'm sure there's a place for that in all of this as well. And certainly in dentistry moving forward, but maybe with education as well.
Yeah, so we're actually doing some stuff now with some universities where we're using it to teach dentists how to read radiographs and take tests and kind of gamify things for them. So we're doing that with a few universities now. We're also using AI to analyze preps of dental students to get non-biased grading. So, like when I was in dental school, I would try to take my prep to the professor that I knew was going to give me the best grade, right? The one that liked me the most. And, it should be really non-biased, and the AI can give that in a second and tell you where you went wrong and why. So someone's asking Pearl. Yeah, that's my company, Pearl, that I'm talking about. So we've done some stuff with education, and we're kind of putting that to the front right now, because so many universities are contacting us saying, hey, remember when you talked to us about that education tool? Well, now our whole school is online, so whatever you can do for that. So we're working pretty hard on that.
Very good. And is it UCLA that you're involved with in terms of universities?
So we're actually doing stuff with UCLA on that. We're working in their dental radiology department, working with their heads. So pretty cool stuff.
Very
Yeah,
good.
we're pretty
Very
lucky.
good. Very good.
Pretty lucky to be working with them.
Moving away from dentistry, I'm always really keen to see your videos and images with your son at Porsche Days Out with all the
Yeah.
classic Porsches, and it's amazing. And has he got the same love for cars and Porsches that you do? Has he started to
Yes.
develop that? Yeah.
Yes, for sure. Yeah, it's been really cool to see. You know, I always say I've infected him with the disease, you know, with the Porsche disease. We'll be driving somewhere and he'll say, Daddy, 911, 911, or Macan or Cayenne. I mean, he knows all the different models, and yeah, it's a special time for us, you know, like Saturdays and Sundays, you know, my wife's stay-at-home mom, so she's with him, you know, all day at home. So on the weekends, I try to give her a break and also just have like me and him time. So usually our car show meetups are on Sundays, and there's always in LA. LA is like the mecca for Porsche, you know, community. So we've got multiple meetups we can go to every weekend, and it's just it's really fun. It's a really special time for me to share with my son. I was going to tell you, I love seeing pictures of your kids too. It's nice to be at this age where we can see our friends and know really what's important, right? We talk so much about dentistry, but who gives a shit about dentistry if, you know, you don't have your family?
Yeah, absolutely. And this time just now that we have been off from work has definitely given us the time, the quality time with our kids.
Yeah.
You know, it's been great just to do some normal things with them. Actually get involved in education a little bit with them. See what they do, how they do it, and also to start to understand them a little bit more. So it's been great, really, really good spending time with them, going out for long walks, and probably it was needed. You know, the whole world needed a little bit of a reset, I think. To allow us just to reassess things a little bit further. You know.
I think that I said on another live, I think that I did this week, is that I think out of all of this coronavirus stuff, kids really benefit the most. I mean, besides, you know, losing family members, let's say, people getting sick, is they have their parents home. And oftentimes, you know, moms and dads are traveling, they're working, they have a bunch of other stuff to do. When you take that out, you can have both parents home, or if there's only one parent, that parent can be home, or the grandparents, or whoever are, you know, the caretakers can be with the kids all day. And so that's pretty cool to see that around the world.
Yeah, absolutely. Everybody's in the same position. You know, whoever you text, whoever you message, whoever you speak to, whatever pictures you're seeing, it's definitely as families or with kids. So actually to be sharing this time at the same time with everybody, it's pretty special. Actually, I think you know we've got to take something positive out of everything. You know, and that's definitely one positive. It's allowed us to do things like read books and catch up on things. You know,
I know.
one of my friends that I run quite a lot, and I was running with him this morning, and he brought me this book. Rich Dad, Poor Dad. I don't know if you read this.
Oh, great. Yeah, I've read that book. Great book.
So I hadn't actually read it, and he said to me, he said, listen, you need to read this book. It just brings things, just realigns things a little bit, you know? What's important in life. So I'm looking forward to getting through that and hopefully a few other books.
Yeah, that's great. So we've got just a few minutes left. Is there anything you'd like to say or give advice to maybe, I have a lot of younger dentist followers. Is there any little tips or advice you may have?
Yeah, a couple of quick things. I've always felt, definitely in dentistry and probably in life, to have mentors is so important.
So important.
You know, so, you know, really, really understand who your mentors can be, try and build a relationship with that person. And because there'll be times when you'll just need to bounce certain things off them. So, you know, really, really try and get a few mentors in your life in terms of dentistry, but also stay up to date. stay up to date and engage and stay in the right communities to try and understand what's happening and the type of dentistry you enjoy.
Yeah.
So, and I think it's a brilliant time for young dentists to be coming through.
It is.
So much exciting stuff going on with digital, with orthodontics. So
yeah.
I think embrace it, but also don't rush at it. I see so many dentists wanting to do everything so quickly. I think just take your time. Good things always come, and also there's more to life than dentistry.
That's a great great topic, because I think that we work our whole life to be a dentist. We spend so much time in high school and in college and in dental school. We're working. Finally, we're a dentist. That all we want to do is dentistry, but we have to remember that there's family and health and eating right and enjoying life and being free and stopping to smell the flowers and not just going home and being a dentist all day. Being able to making sure that you have that separation in your life, right?
Yeah, because I'm sure you've met just as many guys that dentistry is their life. It's so easy to get caught up in that. It's so easy.
Yeah.
So just regular checks, every so often, just sitting back and just checking where you are, what you're doing, and are you giving enough to other things in your life? So I think that's crucial. That is crucial, And we've all done it the wrong way as well. So I'm only giving that advice, I'm only
because we've been there.
Yeah, I wish somebody had said that to me, to be honest.
Yeah.
So, yeah, absolutely. Right,
well,
listen,
good.
You got the weekend to enjoy now?
Thanks so much for taking the time. It's been really great catching up. Hopefully next time is in LA or in Scotland somewhere. I'd love to come see your practice and get the families together.
Most definitely. And hopefully, let's get through this tough time. We're all in the same place, and good health to your family, and stay safe.
Thanks so much. All right, good talking to you. Thanks guys for watching.
Thanks everyone. Thanks. Cheers. Bye.